Now let's discuss some points about lithium toxicity. Uh, we know that lithium is a mood stabilizing drug and that is used in treatment of bipolar affective disorder. It can also be used in refractory depression, a depression that is not responsive to other medical treatment. We can use lithium in the treatment of as an adjunctive therapy in the treatment of refractory depression as well. Therapeutic window or the therapeutic range of lithium is very narrow. That is between 0.4 to 1.0 millimole per liter. It has a long plasma half-life and is excreted primarily by the kidneys. So the half-life of the lithium is very long and it is excreted by the kidneys, and the therapeutic range is 0.4 to 1.0 millimole per liter. And lithium toxicity usually occur after concentration of more than 1.5 millimole per liter. So this is the safe range for lithium. And when lithium concentration in the plasma becomes more than 1.5 millimole per liter, then lithium toxicity can occur. That's why patient need a regular blood test to monitor lithium level every 3 months. And because lithium can cause nephrotoxicity and hepatotoxicity, that's why we need to check liver function test and kidney function tests such as urea and electrolytes every 6 months. So lithium levels every 3 months, and LFTs and KFTs, they are measured every 6 months. Because the dose of lithium varies, hence the lithium plasma concentration is checked in a week from starting the treatment. So initially, when we start the treatment, we need to check the lithium level after 1 week. And then we'll adjust the dose according to the amount of serum lithium concentration. And then the blood test will be again repeated in the next week. And this process is carried out until serum lithium concentration is in appropriate range. So when the serum lithium concentration are in this range, then after this we'll check the lithium levels after every 3 months. So initially after starting the treatment, lithium levels will be checked after a week, and dose will be adjusted according to plasma lithium level. And then this test will be repeated until lithium concentration are in an appropriate range. And after this, lithium ion or plasma lithium concentration will be done every 3 months, and LFTs and kidney function tests, they will be done every 6 months. So a person on lithium for the treatment of bipolar affective disorder, we need to do 3 tests. One is serum lithium concentration every 3 months, and liver function tests and kidney function tests every 6 months. Remember that lithium can stimulate the parathyroid hormone, and excessive secretion of parathyroid hormone can occur, which can lead to hypercalcemia. What are the factors that can precipitate the toxicity of the lithium? Dehydration, renal failure, because lithium is excreted by the kidneys. So renal failure and dehydration, they can precipitate the lithium toxicity. Similarly, anything that decreases GFR, such as diuretics, ACE inhibitors, they decrease the excretion of lithium ions through the kidneys. So they can also precipitate the lithium toxicity. Similarly, as NSAIDs and metronidazole, they also affect the glomeruli. So they can also lead to or they can also precipitate the lithium toxicity. So renal failure and the drugs that decrease the GFR, such as diuretics, ACE inhibitors, ARBs, NSAIDs, and metronidazole, they all can precipitate the toxicity of lithium. Now, what are the features of toxicity of lithium? Coarse tremor. Remember that a fine tremor is seen in the therapeutic levels. So a fine tremor is fine. There's no need to do anything if a person on lithium gets a fine tremor because it is seen in therapeutic levels, while a coarse tremor is seen in lithium toxicity. Hyperreflexia, acute confusion, seizures, and coma. All these symptoms occur because lithium interferes with the neurotransmitter transmission. That's why the person will develop coarse tremor. All the symptoms are CNS symptoms because lithium acts on the nerves mainly. That's why the features of toxicity will include CNS symptoms such as coarse tremor, hyperreflexia, acute confusion, seizure, and coma. Now, what is the management of lithium toxicity? Mild to moderate toxicity is managed with resuscitation with normal saline or IV fluid hydration, and severe toxicity is managed with hemodialysis. Sodium bicarbonate is sometimes used, but there is limited evidence to support this. That's why this point will be not be asked in Plab 1 exam. So you only need to remember 2 points. That is, mild toxicity is treated with IV fluid hydration, and severe toxicity is treated with hemodialysis. So this was all about lithium toxicity, how to identify lithium toxicity and its management. Now a short summary of our key points in lithium toxicity. Lithium is a mood stabilizing drug used in the treatment of bipolar disorder, also as an adjunctive therapy in refractory depression. The features of lithium toxicity, it include coarse tremor, muscle twitching, nausea, vomiting, drowsiness, confusion, hyperreflexia, seizures, and coma. So seizure and coma, they are features of severe toxicity. And severe toxicity will be managed with the most appropriate management for severe toxicity is hemodialysis. Now, what is the initial step if you are suspecting lithium toxicity? The initial step will be to measure the serum lithium levels. And the initial management after taking the serum lithium levels is if there's mild to moderate toxicity,